Hello everyone and welcome again. So continuing our discussion about the clinical pharmacology basic principles class, now we are going to talk about the patient factors affecting response to drugs. So patient response to drugs is different between different individuals, and even a single individual might have different response to the drug during the treatment period. And we mentioned before that the patient response to drugs depends on two factors, or two group of factors. We have the drug factors, which we discussed in the previous video, and we have the patient factors, which will be the topic of this video. So let's start. So we have many patient factors that affect the response to drugs, and those include the age of the patient, the sex, the weight, the pathological status, the pharmacogenetic factors, the tolerance and tachyphylaxis, the rebound effect, and withdrawal effect. And we will explain each one of them in the next slides. So let's start by talking about the age, the sex, the weight, and the pathological status of the patient. So patient response is different between different age groups. Example would be there is a difference between the pediatric patient, which is the children response to drugs, than the adult and than the elderly patient. And also there is difference between the male and the female. Each one might respond differently to different drugs, and between different weights, meaning the body weight also is a factor in patient response to drugs. Also, one important factor in patient response is the pathological status of the patient. So liver or kidney disease significantly alter response to drugs due to altered metabolism. So if there is a liver or kidney impairment, this would lead to altered metabolism of the drug and would lead to different response, might lead to drug accumulation and toxicity. Patient with heart failure more sensitive to digoxin than a patient with normal heart. So if we give a digoxin to a patient with normal heart, they would have no response or minimal response in comparison with patient with heart failure would be sensitive to digoxin. Patient with hyperthyroidism require higher doses of drugs because of fast metabolism. Because of the hyperthyroidism leading to faster metabolism, and so we need higher doses of drugs to compensate for that. So now let's talk about the pharmacogenetic factors. And the pharmacogenetics is the study of the role of the genome in drug response. So sometimes there is difference in drug response between people due to the genetic abnormality that has relation with the drug response. So some people would have genetic abnormality that make them respond differently to a certain drug than another people. And here we are going to give examples of the genetic conditions. Some of them cause exaggerated response and some of them cause decreased response. And let's start with the conditions that cause exaggerated response. And the first one is the pseudocholinesterase deficiency. So the pseudocholinesterase is an enzyme that is normally available in the nerve endings of the nerves in the human body. So it is normally available, and that is to metabolize acetylcholine and some drugs like succinylcholine. So it works on metabolizing acetylcholine and other drugs like succinylcholine, and some individuals with deficient the pseudocholinesterase, when they take the succinylcholine, which is used as a muscle relaxant in surgeries. So the succinylcholine is a drug that is used for muscle relaxation in surgeries, and those type of surgeries that are in body parts that has muscle in them. So we need the muscle relaxation, so it is gonna be easier for us to operate on those parts. So we use a muscle relaxant. An example would be the succinylcholine. So we use it on this person, let's say, and if the person have deficiency of the pseudocholinesterase, this lead to succinylcholine accumulation, because the succinylcholine can't be metabolized by the pseudocholinesterase because the pseudocholinesterase is already deficient. And this would lead to severe muscle paralysis that occurs due to lack of succinylcholine metabolism. And this may lead to death from respiratory paralysis, which is called the succinylcholine apnea. So basically, the succinylcholine would accumulate in the nerve endings and would lead to muscle contraction that is continuous, and this would lead to paralysis of respiratory muscles and would cause death. Another example is the glucose 6-phosphate dehydrogenase deficiency. Now, the G6PD deficiency is the most common human enzyme deficiency, and the G6PD enzyme catalyzes the reduction of the NADP into the NADPH, which maintains glutathione in the red blood cell of the human cells that are available in the blood. And reduced glutathione keeps the hemoglobin in the reduced ferrous form, and prevent formation of methemoglobin. And it also prevent the cell membrane or the RBC cell membrane from injury, which leads to hemolysis caused by oxidative stress. So it basically prevent the cell membrane of the RBC from getting injured by the oxidative stress, because the NADPH or the glutathione is anti-oxidative stress. So individuals with deficiency of the G6PD may suffer acute hemolysis if they are exposed to oxidizing drugs. Now, hemolyzing means the injury to the RBCs that would lead to the death of them, and their contents would be spilled into the circulation. If the person get exposed to that has G6PD deficiency, would be exposed to oxidative stress or oxidizing drugs like the nitrates, the anti-malarial drugs, the sulfonamides, the aspirin, and others. This would lead to hemolysis and would lead to hemolysis, which is injury to red cells because of the oxidative stress. Another example that would lead to exaggeration of the drug response or the patient response to the drug is the thiopurine methyltransferase deficiency, which is the TPMT deficiency. So the TPMT is an enzyme that methylates the thiopurine anti-cancer drugs. Example for the thiopurine anti-cancer drugs are the 6-mercaptopurine and the 6-thioguanine. So this TPMT enzyme would methylate those cancer drugs into less toxic compounds. And genetic deficiency of this enzyme leads to conversion of the thiopurine into more toxic compounds in different pathways. So there is different pathways than the TPMT one that would lead to toxic conversion of these drugs, leading to severe myelotoxicity. Myelotoxicity being toxicity to the bone marrow and bone marrow suppression. So TPMT deficiency prevalence is 1 in 300, and screening before giving the anti-cancer drugs is important because it is common. 1 in 300 people have this deficiency. Another example is the acetylator phenotype. So many drugs are metabolized in the liver by acetylation process, like the isoniazid, which is an antibiotic that is used to treat tuberculosis. So rate of acetylation is different between people, so every person have different rate of acetylation. And there is the rapid acetylators and there is the slow acetylators. And the difference is in genetics. So if isoniazid is given to slow acetylators, this would lead to accumulation and toxicity because the isoniazid would be slowly metabolized and would accumulate and lead to toxicity. And that is by antagonizing the vitamin B6, leading to neuropathy. And that's why the isoniazid is given with vitamin B6. So just in case the patient is a slow acetylator to prevent side effects from happening. Now in patient with fast acetylation, the liver will metabolize the isoniazid faster, and isoniazid metabolites are toxic to the liver, leading to liver injury. And solution is decreasing the dose if you suspect patient is fast acetylator. So if it's slow acetylator, we give vitamin B6, and if fast acetylator, we decrease the dose. Fast acetylators complain of liver symptoms, slow acetylators complain of a neuropathy. So pay attention for that. So hydralazine is also metabolized by acetylation, and if given to slow acetylators, this would lead to SLE-like symptoms. SLE being systemic lupus erythematosus, and it is a connective tissue disease. Now let's talk about examples that cause decrease in patient response to drugs. So we talked about the examples that cause increased drug response, but now the ones that cause decrease in drug response. And the first one is resistance to coumarin anticoagulants, the warfarin and INSI group. So coumarin anticoagulants, example for them is warfarin. And so liver synthesized clotting factors 1972, so 10, 9, 7 and 2, which are abbreviated in the mnemonic 1972 by the help of the enzyme vitamin K epoxide reductase. So liver synthesized those enzymes by the help of this enzyme, or the clotting factors by the help of the enzyme, and warfarin inhibit the enzyme, which is the vitamin K epoxide reductase, to give the anticoagulant effect. Some people have abnormal variant of the enzyme being the vitamin K epoxide reductase, leading to warfarin not working on it because it is abnormal variant, so warfarin would not work on it. And some people have another enzyme similar to the vitamin K epoxide reductase, so liver inhibit the epoxide reductase, but it would not inhibit the other enzyme. So liver would has another enzyme that do the function, and would still synthesize the clotting factors. And when we use the warfarin, we don't have the anticoagulant effect whatsoever. So that's the first example of the decreased drug response, is decrease the anticoagulation effect. Another example is the vitamin D resistant rickets. So there's a variant of the rickets disease that is X-linked and that is resistant to the vitamin D, doesn't respond to the vitamin D. And the third example is the darker eye color, the more resistant to the mydriatic topical drugs. So the people with dark color eyes would have resistance to the mydriatic topical drugs. And the lighter the color, the more sensitive it is, and is related to the genetics. Now let's talk about the fourth patient factor affecting the response to drugs, and that is being the tolerance and the tachyphylaxis. So tolerance means progressive decrease in a drug response with successive administration. So the more the patient takes the drug, with time, the more the response would be decreased. And the same response could be obtained by higher doses. So we increase the dose to solve this. And it occurs over a long period of time. Example for that is alcohol drinkers. They would be drunk by a little alcohol in the beginning, but with time, they need more alcohol to be drunk, to get drunk. Yeah, so that's an example for that. So tolerance, again, progressive decrease in drug response with successive administrations. Tachyphylaxis, on the other hand, is an acute type of tolerance that occurs very rapidly. So tolerance occurs over a long period of time. Tachyphylaxis occurs very rapidly, so it is an acute type of tolerance. And body tries to do the opposite of the drug action. So if the drug, let's say, is alcohol making you drunk, the body would try to do the opposite, and that would make you need more dose to get drunk. And so the body always try to do the opposite of the drug action. So we have three mechanisms of tolerance. The first one being the pharmacodynamic tolerance. We also have the pharmacokinetic tolerance and the behavioral tolerance. So let's start with the pharmacodynamic tolerance. And that is due to three causes. It is either the receptor desensitization. So the receptor gets desensitized with time. So prolonged exposure to drug leads to slow conformational changes in the receptor, by which the receptor shape become no longer suitable for the drug. So with time, the receptor shape would change in a way that makes the drug unable to bind to the receptor anymore. And that's being the receptor desensitization. The other mechanism of the pharmacodynamic mechanisms is the receptor downregulation. So downregulation, so prolonged exposure to the drug leads to decrease in the number of receptors, of the functional receptors. The third one is exhaustion of mediators, so depletion of the catecholamine. So example for that, it would be the depletion of the catecholamines by the amphetamine. So amphetamine secretes the norepinephrine from the nerve endings, leading to decrease the norepinephrine. So basically the amphetamine lead to exhaustion of mediators through secreting all the norepinephrine at once and keeping no norepinephrine for the next times. So in the pharmacodynamic tolerance, we have three mechanisms. We have the receptor desensitization, we have the receptor downregulation, and we have the exhaustion of mediators. So the other tolerance mechanism is the pharmacokinetic tolerance, and that is due to increase in the metabolism or metabolic degradation of a drug by induction of the hepatic enzymes. So we all know that metabolism or metabolic degradation of drugs is a pharmacokinetic property, and increase of metabolic degradation of the enzymes, of hepatic enzymes, example would be with the chronic administration of ethanol. So basically the liver would degrade the ethanol more quickly by the induction of the enzymes, and this would lead to tolerance of the ethanol. The third mechanism is the behavioral tolerance, and that's when a drug-independent learning of the brain how to actively overcome a certain drug-induced effect. So basically the brain would try to overcome the drug effects through practice. An example would be the psychoactive drugs. So overcoming tolerance. So how we overcome tolerance? We can overcome it by drug-free intervals. So basically, we give the drug for a certain time and then we stop the drug for a certain time until the body goes back to normal, and then we give the drug again. So we overcome tolerance this way. Also, we can overcome it by using a drug with a different mechanism. So once the body have tolerance to a certain drug, we give a drug that has a different mechanism than the first drug, but it produces the same effect, or a different target receptor. And now finally we have the rebound effect and the withdrawal effect. So the rebound effect is recurring of symptoms in exaggerated form. So basically, the symptoms before we give the drug reoccur but with exaggeration, meaning the symptoms become very exaggerated when a drug is suddenly stopped after a long period of administration. So basically, let's say we have a patient that has high blood pressure. So his blood pressure is higher than normal, and we gave them a drug, let's say it's a beta blocker drug that reduces the blood pressure, and the patient used the beta blocker for a long time, and suddenly the patient stopped taking the drug. And after that the patient had a hypertensive crisis, meaning his blood pressure is back to being high, but this time it is even higher than previous blood pressure before using the beta blocker. So it is recurring of symptoms with exaggerated form when a drug is suddenly stopped. And mechanism of the rebound effect is the prolonged administration of the antagonist lead to up-regulation, increased number of receptors. So when we use, let's say, an antagonist like a beta blocker, there is an increase in the beta receptors. So there is an increase in the beta receptors in the body, increase in number of the receptors, or increase in the sensitivity of the receptors. So they would be more sensitive to the adrenergic enzymes or adrenergic hormones. So when the antagonist is suddenly stopped, severe reaction occurs. Severe tachycardia and arrhythmia occurs after sudden stoppage of beta blockers. So example would be tachycardia and arrhythmia after stopping the beta blockers. So the mechanism of the rebound effect is either upregulation of receptors or increased sensitivity of receptors. Withdrawal effect, on the other hand, is the same as the rebound effect, but is recurring of symptoms in exaggerated form plus addition of new symptoms. So withdrawal effect would be there is a new symptoms in addition to the previous symptoms. So when a drug is suddenly stopped, withdrawal effect, example would be withdrawal effects that occur after sudden stopping of opioids in opioid addicts. So basically, a patient, let's say, is on opioid drug and would stop suddenly. So they would get suicidal thoughts in addition to their depression, which was already existing before the drug use. So again, the body does the opposite of the drug action. So in case we use a beta blocker, the body would try to upregulate the receptors, so the beta blocker effect would be decreased. So always remember this, the body does the opposite of the drug action. And it is applicable to the rebound effect, and it's applicable also to the tolerance. So here we have some drugs that causes rebound effect after stopping them. So we have the beta blocker. When there is sudden withdrawal of the beta blockers, we have severe tachycardia, arrhythmia, and even myocardial infarction might occur. Clonidine, it's an anti-hypertensive drug, so we would get hypertensive crisis. Cimetidine, on the other hand, it's an anti-acid, so we would get severe hyperacidity and even might get peptic ulceration. Corticosteroids, we would get Addison crisis. Morphine, we would get anxiety, agitation, insomnia, muscle aches, sweating, and even more symptoms after we withdraw the morphine. If we withdraw the warfarin, we will get risk of thrombosis. Here we have a comparison between the tolerance and the rebound effect, so you have clear definitions for them. So the tolerance occurs when the body becomes accustomed to a drug and requires more of it to achieve the same effect. So basically, it is decreasing drug effect with successive administrations. The rebound effect, on the other hand, occurs when the body experiences withdrawal symptoms on exaggeration, return of symptoms after stopping or reducing use of drug. So basically, the rebound effect occurs when we stop the drug. The tolerance occurs when we administer the drug for a long time. Tolerance develops over time with the prolonged use. Rebound can occur immediately or shortly after stopping reducing the drug. Tolerance can lead to increased dosage or frequency of the drug use. Rebound lead to withdrawal symptoms or an exacerbation of original condition. Examples would be, for tolerance, tolerance to pain medications, sedatives, and opioids. For rebound effect would be rebound headaches from overuse of pain medications, anxiety and depression after stopping antidepressants. And with that, we reach the end of this video. Thank you for watching. Please make sure to like and subscribe. And if you want to support more, you can by subscribing to the Patreon link provided in the description of this video. Thank you for watching and see you soon. Peace.